Hypermobility is prevalent. It's absolutely everywhere, and you may have missed it and messed up a few patients, but that's okay. I'm going to tell you how you can move forward and how you could do better, be better, because that's what we're all about here. Hi, hello. In case we haven't met yet, I'm Carice. I am your Myo best friend, and I am here to help every week. At this point, I started to count it up, and we're probably at 100 hours of continuing education. No, you don't get any CE credits for it, but hello, you get to up level yourself and be better as a therapist for $0 here on YouTube and on LinkedIn. So please join me every single week. I am here and I am just always trying to be better myself. And I believe that this field can be better and practice at a level of excellence that we are not yet at. I don't believe in gatekeeping. I really think that it's interesting that hypermobility has been such a topic that has been gate kept. And it's like, ooh, buy my course, take my thing, I'll tell you about it, join my group, whatever. But we're about to talk about it. We're getting into it, okay? So if you haven't already, subscribe, like, make sure you comment. Please give me a hi, hello in the comments. Like, do something to help this grow. Who else do you know has 100 free hours of content online for you, okay? Nobody. With that being said, if you are looking for really, really great content, the International Association of Airway Hygienists is a phenomenal organization that I put my time, my heart, my love, my passion into. And we are doing so many great things for the field for hygienists specifically. One of those is supporting my favorite conference and the only airway conference that you will see me at this year and probably for a few years to come. But Myosphere, if you have not signed up for Myosphere, it is this April, okay? The room blocks are selling out fast. I'm telling you, this is the place to be. If you come for nothing else than Dr. Neal's presentation on like how you can help with floor of mouth tension by dealing with the rest of the body, like hi, hello, you need to be in this room, okay? So I think that also goes very hand in hand with exactly what we're going to talk about today. So just hitting you with some of the tea, but Myosphere. The IAH is the top sponsor for the Myosphere conference, which is why I had to put this in here, because if you want to learn more about the IAH, how you can get involved, how we help with legal fees and dues and all sorts of things for the lowest of prices of all organizations, okay? I'm not out here to grab all your money. I am here to lift you all up so that we can be great together. And so Myosphere is a great place where people do that. And with that being said, no further ado, let's get into some of this laxity. So this is actually supposed to be a gift. It's supposed to be the people are like moving, but I guess they don't want to move today. So that's fine. We're going to talk about laxity. When we speak about laxity, I think it's important that and we're going to get into it, that we really disassociate the idea of hypermobility really being just a laxity thing. It's not necessarily muscles are lax and that they're just hypermobile. It is so much deeper, so much greater, and all of it has a great impact. When we talk about myofunctional therapy, we need to stop talking about it as if it operates within like a little box and we just do fine motor movements and all you ever need to learn about is fine motor. And if there is anything going on gross, well, just discard it, throw it away. This is not needed information. I really think we need to get to a point where we start looking at our patients from a different perspective, because we have a lot of these wavy men and women that come into our practices, whether you're practicing just in traditional clinical dentistry, you're practicing in traditional speech language pathology, you are practicing in whatever domain you practice in clinically, I guarantee you are seeing hypermobility, and some of it doesn't matter at all. Others of it matters a lot. Yeah. Carice, what do you mean? Like, I don't understand. Like, what does all of this even mean about the joints and the laxity? Well, I want to do an analogy. Nothing helps me learn better than like a really good analogy. And so if I have a good analogy, I'm going to share it with you. So a tent, and I would say imagine a tent, but just look at the tent, okay? You're going to look at the tent, and I want you to look and to see that the tent, it has these poles, and some of them, you drive into the ground, and it keeps a nice rigid state about the tent, right? So the wind will come and there's some flex, but it won't be like super wobbly because it is very stable and well supported. So the structures that are helping to support the fabrics of the tent are stable. We get them stable. Okay. So there is some flex. There has to be some flex. We're not in a brick tent. There's flex, but it's mostly stable. Now, let's talk about hypermobility as if we replaced all of those stable lines for the tent with bungee cord. Bungee cord being flexible, extra stretchy. Now imagine a wind comes by and a wind blows this tent. This tent would be our, car wavy man salesperson outside that would just be blowing through the breeze. Can it provide some structure? Will the tent be relatively okay on a day where there's zero wind? Sure. But how many days do we get where there's zero wind? I want you to think that this is the connective tissue for your people who are struggling with hypermobility. And every day in their life is wind coming, and they have to work much harder to keep the stability of this tent that's now, yes, reached the maximum of what the capability for those bungee cords' stretch could be. And they're trying not to blow away in the wind. And it's constant, it's chronic, it builds, and they have to keep it steady and stable. And any way possible they can keep that stability, their body will find it. Are they consciously fighting it and trying to keep stable, all the time? No. No. They don't know it consciously. They are subconsciously compensating, and in doing so are supporting their tent the best way they can. So their body has extra flex beyond what traditionally others have. Okay. So imagine, the type of autonomic nervous system regulation that would come with that. It's a lot of what we already get with Airway. You can't get good sleep with that. There's so many correlations between obstructive sleep apnea or just sleep disordered breathing and hypermobility. Everything just kind of comes together. They have a bigger instance of TMD and oral facial pain. And so this all comes together with what we are looking at. So when I tell you that you've probably seen it before and you may not have known what to do about it, I've definitely seen it, and I've worked with plenty of people and had no idea what to do about it. So don't feel like anything I'm telling you is like brand new information for just you alone. I love learning for all of us. Okay. So we're all going to win at the end of this. But what I have learned over the years in like my near decade of doing myofunctional therapy is that it's not all equal, and that there are some people who will actually nothing is all equal, but I will tell you hypermobility is not all equal. When people talk about hypermobility, I think there's a tendency to overgeneralize and to give everybody hypermobility who might have one or two signs of it without any true further testing or without any true further official diagnosis, because hypermobility in and of itself, generalized hypermobility, is not actually a diagnosis. There is a spectrum of hypermobility, and so the hypermobility spectrum disorder, that could be a diagnosis, or hypermobile Ehlers-Danlos syndrome is another more genetic based disorder that's like an official diagnosis, but not all of it is equal. There is benign hypermobility that you don't have to be as on guard about because it lacks some of the systemic parts of what we would really be dealing with diagnosed hypermobility. So if you can do the splits and you're like, oh no, am I hypermobile? Like, do I have a problem? Am I bracing all the time? But you don't have some of the other things that we'll talk about today, then maybe it's not as big of an issue. Okay. So emphasize, not all hypermobility is equal. Right. So let's talk about the different types of hypermobility. There is benign hypermobility. Oh, sorry. There is benign hypermobility. It's not a diagnosis. It's just a description that they are hypermobile, but maybe in just an area. Maybe they can do a cool party trick, like get their thumb to touch their forearm or whatever. I can't do it, so I can't even like show you. But maybe they do have some form of flexibility. So in our tent arrangement, that would be the tent is still some bungee cords, but there's not really anything going on that's disruptive outside. So they have no symptoms, no real display, but they have a cool party trick. Imagine that. Okay. Hypermobility spectrum disorder does not meet the classification where there are some systemic issues that would make it a hypermobile Ehlers-Danlos syndrome. It is that it is hypermobility where it's the beginning stages of it is affecting you, but you are just starting to meet some of the criteria that would have it be an official diagnosis without it being a genetic autosomal association. Okay. Ehlers-Danlos syndrome, there are 13 subtypes. So not everybody that has Ehlers-Danlos is hypermobile per se. There are 13 different subtypes. I read somewhere that there's 17 different subtypes. I've actually been doing a lot of reading, and there's a really great book I want to recommend for you guys, but I'm going to save that for my next live. So tune in next time. If you haven't subscribed, make sure you subscribe so that you get that. But that there are 17 subtypes of Ehlers-Danlos, some that are more recognized than others. So when we categorize somebody as having EDS, I think it's really important, one, that we recognize that myofunctional therapy, pseudoscience, okay? We are not licensed professionals in any capacity. And so there is no scope of practice or overarching legislation that we can even diagnose something like Ehlers-Danlos and or hypermobility. And so you want to be careful that you read deeper, learn deeper, know more where exactly you're coming from if you're going to characterize it as hypermobile Ehlers-Danlos. If you're going to ask somebody if they have Ehlers-Danlos, there's very specific testing that would be done for that. That is not a part of a routine physical that we have in America. And so it's really important that we start to realize that there's a spectrum where it could be nothing, it could be the beginnings of something, or it could be something really big that's impacted your life in many ways. And so it's well beyond these cords, these bungee cords of the tent. It's also, the fabric is a little weaker. And so people with Ehlers-Danlos might have more loose skin, or there's more signs, more systemic signs is where I would leave it at that. So not all hypermobility is equal, and not everybody with Ehlers-Danlos is the same, because in so many threads, EDS is thrown out everywhere by patients and practitioners alike, and it's not the same. There are many subtypes. It's highly debated. There are so many people in the scientific medical community that do not agree on so many of the things with Ehlers-Danlos. And while that's not criteria in and of itself, I just have to remind us of where we are. We're talking about myofunctional therapy. It is in and of itself a pseudoscience. You are not a practitioner. You cannot diagnose. And so be careful who you're going out there mentioning Ehlers-Danlos to if you have not the criteria upon which to make such a diagnosis or a claim for someone. Okay. Hypermobility is not flexibility. I started to talk about this and I had to pull in the reins a little bit earlier, but hypermobility, I want you to think about somebody who might be able to, I think that might be the next slide too. Yay. Hypermobility. I want you to think about somebody who might be able to touch the floor or touch their toes. You can, with flexibility, reach down and touch your toes. And I want you to look at the arch of the people. So this arch is mostly the hip hinge, right? The hip hinge is where we would have the hypermobility. If it's true hypermobility, that hip hinge, it's not just the muscles that are bending down and stretching a little bit to reach, it is your joints that will boop, get you all the way over into that full forward bend. And that would then be instead of flexibility. So you could work on your flexibility. You can do yoga or Pilates or a lot of the things that people do to stretch and improve their flexibility. But it's not flexibility. Being flexible, being able to do the splits is not the same thing as being able to actually overextend a joint and a hinge. So your hip being able to rotate far enough forward that you can get both hands flat on the ground, not just kind of touching the ground, flat on the ground. This is a full hinge, and you see it gets progressive. So this is like bending over. This is a, a good hinge, but this is like a full hip hinge. And so there's a difference here. It's a spectrum of things. So what's important to know is that flexibility is always a goal for us. We're always going for flexibility. We want people to be able to maximize their range of motion, particularly with their tongues. We're always looking for that, right? We want them, if they have limited temporomandibular joint opening, so they can only depress but so far, we want to enhance the flexibility of the musculature involved in opening, closing, in elevating the tongue, protruding, retracting, suction, whatever. Flexibility is our goal, whereas hypermobility can be a complication that results and can be a complication where we're going to experience an increase in the compounding problems. So we're making some of that bungee cord just a little bit too flexible. So now it's even harder for them to achieve stability. Their hypermobility has created this hinge action that we did not intend to happen. So if you have somebody who is opening and you're measuring their maximum opening, so their maximum opening of their mouth, and you're finding that you're in the 60s, in the 70s, and you're like, oh, wow, you've got such a great big jaw opening. There might have been some translation in that jaw too, where they're opening and sliding forward. And so now they're coming off of the hinge in an odd way to achieve that. And you don't want to work from that area in that space where you might be looking at, okay, so if this is their maximum opening, and then this is their maximum opening with their tongue in elevation, and we haven't worked on any of the flexibility for that tongue, we don't know what their maximum capability for tongue range of motion could be, but we're looking at an overcompensation in their maximum opening. How are you measuring 50% for that? How are you looking at that as that's where they're supposed to be? And then what does that mean for your myofunctional therapy? We got to put on our thinking caps. I think it's incredibly important as a myofunctional therapist to be able to independently determine what that person needs. And I was thinking about it the other day. It's almost like getting a franchise, doing some of the courses with the cookie cutter stuff. It's like getting a franchise and now you're slinging somebody else's McNuggets. Like you're out here pushing McNuggets as if you invented McDonald's, and you did not. You are not Ray Kroc. Like you did not. So it's really important that we know a couple of things. Okay. So I'm going to really like hone in on what these 5 things are that you need to know as a myofunctional therapist. Number 1, stability will always need to precede mobility. You need to stabilize in a lot of different ways, and I'll give you some changes that you can make. Modifications is the word that I want. Modifications that you can make to some of your exercises. I'm going to give you 3 specific exercises that you can make some modifications on. That way you can increase stability, because when you are allowing them to have too much motion, you're not regulating the wind speed that's out there coming at their tent. Okay. So you're making them more stable, even though they're already a little bit more mobile in some ways, and you're creating more instability. So your goal as a myofunctional therapist is to establish stability. Then from there, you can create additional mobility. Because when you over strengthen joints that are unstable, you're going to make it worse. So you have to create stability. Sometimes that's intraoral, and you might use like a prop, right? Sometimes it's extraoral, and they might have to actually hold and support and ensure that they're not creating any additional compensatory movements. Okay. Stability precedes mobility every single time. Okay. Number 2, endurance will always need to come before intensity. You don't need them to do anything at their maximum range. You do need to make sure that you're able to temper down what you're doing as far as how many reps. What's interesting is that I work with a broad spectrum of people, and more frequently, it's been people who have done some form of myofunctional therapy or physical therapy to deal with their temporomandibular joint, or to deal with tongue sucking habits, or like these bigger, greater cases where I'm dealing with MDs and, PhDs in kinesiology and PTs as my clients, people who are significantly smarter than me but can't figure this stuff out. But a lot of the times they're looking at me when I give them odd numbers. So I'm like, I want you to do this 3 times. I want you to do this 7 times. And they're like, this doesn't happen in physical therapy. Like, we do nice round numbers. It's 5 or it's 10. Like, what is this 3 or 7? It's me as a therapist. I am not distributing something I learned from someone else. I'm looking at how you are performing. I'm looking at how you are able to manage your compensations while you're doing a task, but I want to minimize any chance that your body is going to try to overcompensate, or you're going to do something too fast, or you're going to do something where now when I see you after a week or 2 weeks or 3 weeks or however long our intervals are, you've been doing so much loading that now I've created pain in places I didn't intend to. So your endurance level, you're going to tire out quickly. And I know we need to stop at 3. I need you to do this, and I need you to do it in repetition. But 3 is going to be your stopping point before we start hitting some you're tired and you're trying to now overcompensate to achieve the same task. Okay. So it doesn't look like myofunctional therapy doesn't look like physical therapy. And I really wish people would stop using that analogy. It's not good. It's terrible, actually. The more physical therapists I work with, the more I'm like, this is not the same. But it's more attuned to the really fine changes in movement that become and that happen and occur in your patient, and being able to look, watch the sequence, follow the flow, ask how they're doing. There's nobody who will ask how you're doing more than me. I will be the annoying person that at some point you're like, it's fine. Okay, you're saying it's fine, but here's what I'm seeing. I'm seeing your jaw starting to protrude as you were doing this, and I'm also seeing a shakiness and instability. Okay, you're right. A little bit. I'm starting to fatigue. Yes, we taught the exercise. We tried the exercise. We repeated the exercise. So we only did it 3 times. But in that time, you fatigued. Great. In hypermobility, that will happen. they will load. They will have nervous system dysregulation going on, and they will turn on all the compensations. And what you want to make sure of that you're always doing is one, checking in and being careful with how many reps you're asking them to do, and the time frame of which you need to get outcomes. So if I see somebody who's hypermobile, I'm not seeing them once a week. Why would I do that? They're going to need less reps, but over more time to build out the stability. So their endurance, and being mindful of their endurance, is always going to be greater than the intensity. So you've got 10 reps of something, or you've got them doing it for a minute when they really need to be less, because less is more, because you don't want to overload. Okay. Let me know if I'm not hitting with you, like in the comments. If you're like, I'm so confused, Carice, put it in the comments. Let's get clarity, because that's the only way for us to get better. Okay. I will check the comments later, because right now I'm moving on. Breath is everything. Breathing is how we're able to better regulate. I make sure that there is breathing in every appointment that I do with everybody that I see. But particularly, we want to turn on some of our nervous system, autonomic nervous system regulation. So whether I'm starting you on the ground and we're doing, Stanley Rosenberg's basic exercise, and we're resetting and we're really getting you into a good place of social engagement with your vagal tone, or we're doing breath work that's going to downregulate you so that you're not in a high sympathetic frequency, we can achieve some stability. Getting that nervous system regulation will actually help them be better able to get sensory perception and therefore achieve greater stability, because now their perception is enhanced. You'll find with hypermobility, they don't have really good proprioception, interoception. They have no idea what's going on. Sometimes they really sometimes didn't even know that they had a cool party trick until you ask them. What I do during a lot of my evaluations is, especially with children, but sometimes with adults, because they understand what a cool party trick is. But I will tell them, like, hey, I want to see all of your cool tongue tricks. Like, I want to see all your cool party tricks. Like, what you got? And they don't even realize that they have some cool party tricks until they start doing some things. And like, oh, I had no idea that I could do that. They've never done these things at their maximum range. So when I'm asking them for maximum opening, or I'm feeling the jaw and I'm watching it move, and I'm seeing that shift where it's opening too wide that now it's starting to protrude, like, oh, did you know that you could do that? You have really cool party tricks. Interesting. But the breath is everything. It helps to avoid any sort of dysregulation that can occur and to just achieve a better stability, enhanced stability. Posture matters. So all of your slumpers, all of your people who will be in a seat when you're doing myo. I love doing myo standing. I love getting up and like doing stuff. I love, just keeping the blood flowing and getting us all to be better. Posture matters for a lot of things, but with hypermobility, posture really matters, because in some of the bigger spectrums where it's not just benign hypermobility, where you might be in that hypermobile spectrum disorder, or you might be in the HEDS, you might be in the hypermobile Ehlers-Danlos, you've got either the startings of which or systemic global gross motor incorporation with your hypermobility. And that's going to create instability along the spine, along the cervical spine, where, we're working a lot of our forward head posture and things that do come along with that wind up being a part of it. You want to achieve a sort of neutrality with your pelvic floor. If you don't know, and you haven't heard me say it before, our three arches in our body need to be connected, and that's how we create a really good stabilization, gross motor wise, a really good stabilization. Our top arch is the palate. Our middle arch is our diaphragm, right? Our third arch is our feet. So those of you who have flat feet, whatever, yours is a more tiny, less able to see arch, but it's there, okay? We know our tongue connects our body straight through our diaphragm all the way down to our toes through that deep line fascia. And when it is connected in proper oral resting posture with our palate, that top arch, we have all three connected and we're better able to achieve neutrality in our posture. And so you can improve the gait because a lot of hypermobility might include a gait where the gait is off, their posture is unstable. They may have like a forward tilt that they don't even realize they have. And so we've got issues there that we need to make sure we're dealing with. So if you are a therapist who deals with posture, be more mindful that hypermobility in your mind should very much translate into now we got to do some postural work. If you're not, then guess what? Collaboration matters. You have to know who you can collaborate with, who you can refer hypermobility to, because they're almost always interdisciplinary cases. You should never be working on somebody alone as a myofunctional therapist. If that is their choice, I tell people all the time, if you choose, if I'm telling you, you need to see this person, that person, and you decide you're only going to work with me, that is your choice. But I will always tell you that you need like a full gamut of things because it's a team therapy. It is something that is always best. It is not dynamic in and of itself, which is why I go to learn different things, which is why I do incorporate breath work and cranial nerve integration and primitive reflexes and other things and energy work and posture. We incorporate a bunch of things into my program because myofunctional therapy in and of itself isn't going to fix anybody. It's not. Point blank, period. That's why we need so many other things. But collaboration is definitely key for hypermobility because their joints are unstable. Like if there's systemic inclusions, a part of that, they may have gastrointestinal issues, chronic allergies. And when you see hypermobility, gastrointestinal issues, and I just said it, and then already it's lost me. Chronic allergies. You're looking at the possibility for MCAS, and that's way out of your wheelhouse. That's somebody else that you need to incorporate. You need to get like a different practitioner and provider. And actually, while I'm on that, I'm going to just pump this up right now that I've created some resources for you guys. And so if you are a member of the Myo community on Facebook, you can get just free info. Yay. Everybody wants and loves free info. A quick guide. So clinical quick reference with everything I'm talking about today and things you need to look for and things you need to look out for. And then like a questionnaire, a screening questionnaire. So absolutely free if you're part of the Myo community on Facebook. Okay. I'm not going to put it in there. You're going to need to ask for it within the Myo community. That's how I know you would have watched this because it's not just going to everybody. You got to actually watch in order to understand. All right. So with that said, what does it look like? What does it look like in an airway? Well, the joint is unstable. Do you ever have people who tell you that like either their child or themselves frequently kind of moving the jaw? They can't figure out a nice resting position. They feel like their teeth don't quite touch in the way that they would like them to. They struggle a bit with that. And that's instability of the temporomandibular joint. And that instability might be a sign that, there might be some issues there. Anytime I'm like, oh, you have a hard time finding your centric relation. All right, let me prepare myself for possible isolated hypermobility of the temporomandibular joint, or let me prepare myself for the fact that we might have global concerns and systemic indications that I need to manage better. Jaw clicking without pain, it's different than jaw clicking with fatigue. Okay. Jaw clicking with fatigue might be some of that endurance, lower endurance, that hypermobile. They're fighting for their lives every day, trying to hold that tent, keep that tent together. Just keep that tent in your mind. The tent works for me every time. That's how I explain it to patients. Like the tent, that's what it is. You're fighting for your life, trying to keep that tent from blowing away, and you're trying to just sleep. You can't sleep because the tent might blow away and you would be just out of luck. Tongue fatigue. They might have a lot of good strength, but they feel like their tongue gets tired. Adults who talk a lot, or kids even say sometimes that they get tired when they talk a lot, but adults who talk for a living and who might be on phones all day or in meetings all day or having to communicate with others for what they do. And they just say, oh, my tongue, it's just so tired at the end of the day, but I can do all these things. I looked up exercises on YouTube. I can do them. I can hold a suction. I can do this. I can do that. Okay. You might be hypermobile, sir or ma'am. There might be additional compensations that we haven't looked at yet that need to be addressed. Okay, low endurance, same, that fatigue. Mouth breathing. The jaw is hinged open all the time. I think mouth breathing is like a cause for everything. If you stop mouth breathing, then likely your life will improve in a number of ways, but it's involved, mouth breathing. Collapsing posture, so like their posture is poor and you see like they've got the forward head, and or they do a lot of that collapsing posture, like they might sleep in a what's that, fetal position, in a fetal position, bruxism, trying to find that stability even in, so that's like a different form of that TMJ instability is bruxism. Okay. But they're trying to find that stability. It might also look like a couple of other things like scallop tongue. Scallop tongue could be that bracing for stability. And I tell people that all the time, that clenching, you're bracing, you're trying to get stability, you're trying to achieve stability where there might not be any. Gorlin sign, those people who got the coolest tongue trick. I think the coolest tongue trick, honestly, is being able to create a clover. But they have the coolest tongue trick where they can get their tongue to reach their nose. I've got a fun fact about giraffes. I always talk about my giraffes and how like obsessed I am with giraffes now. But I've got a fun fact about giraffes. If you haven't heard it, ask for it in the comments. Happy to give it to you. Palatal arch shape is high. That arch, it just collapses. It's not able to give the structure that we want or we expect from our palatal arch. Translation of the TMJ, it's excessive. There are some people who are like, look how far I can move my jaw. Like, that's not impressive. That is a compensation, sir. And so make sure that you're aware. Fragile skin, easy to bruise. People will tell you they're easy to bruise. That's a big one. People who say that they can't get numb, like they're in your dental chair and they're like, lidocaine is really, it doesn't do very much for me. Like it's difficult for me to get numb. Red flag for hypermobility. Okay. And that's on the guide too. So make sure you join the group so that you get the guide. And forward head posture, different types of compensation. Okay. So a word of caution, because everybody makes these mistakes. And I feel like education is incredibly important. And if you are not educating yourself, you should at least be educating your patients. But education is incredibly important. And if you see things, what happens is we make these same mistakes over and over and over. If you see things like overdeveloped masseters or a tight floor of mouth, so much talk about floor of mouth and like everybody gets it wrong. Floor of mouth is not like everything that people make it out to be. I have very, very, very sharp opinions about everything. However, the floor of mouth overhype is a big one. But if you see a tight floor of mouth, or they say they have a stiff neck, or they have difficulty kind of turning from one way to the other, and they're like, oh, I feel really tight. Immediately you're like, oh, tongue tie, right? That's where your clinical mind goes. Well, no, not tongue tie. But you also go into like, you need this loosened, right? We need to wind down. Your masseters are too strong. We got to wind them down, right? In hypermobile people, they're not tight for the reason you think they are. It's more of that bracing that's causing those masseters to be tight, right? They're finding their stability. That floor of mouth might be tight because it's really just been holding and trying to hold the tongue in this position in the middle of the mouth against the teeth, or grabbing on wherever it can. It's guarding. It's like the person holding up the tent. So stretching or loosening those muscles that are super tight, or jumping right into, we need a release. This is, again, ask me why. You don't have to ask me why, because there's a whole video about it. Why tongue tie is the modern medical scam. Because there's so much we're not looking at when we just start jumping into, oh, this looks tight. You need to look at the function. It's incredibly important that you start regarding the function with as much high level of praise as you do the appearance or the feel of tissue. Okay? Because where they were bracing, if you start stretching now, they're more unstable. You've now made things extremely worse. Where there was support for the jaw, there's now no support, and you haven't gotten to the greater levels of the program. If you're doing myofunctional therapy as a therapist, you typically are doing it with a sequence that builds on itself. And so you haven't gotten to those higher levels yet. Tongue tie is typically done at the lower levels of the program, creating a foundation of support, but you haven't established proper oral resting posture. So where's your stability? You've now created increased instability in that person. And then you're going to get the rebound where now it's like, oh, okay, there's no more tension. That must mean that maybe we don't need to brace anymore, and everything becomes super light, or even more tight, because your brain is now messing with the body and saying, oh, things have changed here. I guess the tent isn't going to blow away, and things become more lax, or they rebound and become more tight. And they're like, oh, I got this tongue tie release, but now I'm tighter than ever, even though I did everything I was supposed to do. Are you hypermobile? Because that might have played a role in everything that nobody really took a look at before they went cutting up your body in a surgery. And then ligamentous creep, which is, you're stretching. Let's say we can stretch. Remember, that original tent, or the tent as it's intended to be, has some give. It has a little bit of stretch, but it's not overly stretchy like the bungee cords. Okay. So if you have the bungee cords and you stretch even more those bungee cords that had the capability to be stretchy, and you make those at their maximum stretch, well, now you just made bungee cords that are just a little bit more loose. You've loosened up a bungee cord. Yay, you. Right? You've made it worse. You've made it worse, and you might have a person that might trigger in your mind now, like, oh man, that was so-and-so's case where we just didn't get the progress we thought we were going to get, or we did a release and then we knew we had to do another release, and then, oh my gosh, is that what happened? Possibly. This is why it's interdisciplinary, because you're there for the function and to help, and I'm always looking to see where I can functionally improve somebody before we get into, okay, I'm going to need you to do this permanent modification to your body. I think it's incredibly important that if we're root cause, because that's what Myo really champions itself on, we are root cause providers. We are a holistic solution. We are a natural approach, that we need to start thinking as such. There are ways that we can really strategically match and meet our people where they are. Okay. And so, let's make a couple of updates to kind of round us out here. All right. So 3 exercises, just in case you don't know what these are, because everybody calls their things different. Some people might call tongue pops tongue clicks. I call them tongue pops because it just sounds a little bit more mature. If it's like a kid, then I'll call them like horse clicks or horse clops, because it sounds like a horse going. kind of walking along. But tongue pops, I don't know. That's what I call them. Tongue goes up, it holds suction for 3 seconds, it comes back down. That's a tongue pop from my understanding of it, or from what we're going to lecture on today. Tongue to spot should be self-explanatory, and I hope everybody calls it such. But that tongue elevating up the spot, holding. Some people have it hold in static hold. I typically will have it hold and then come down and then go up and then come down and then go up. Like, it's not a static hold for me unless they're on the vibration plate over there. If they are on the vibration plate, then it's static for different types of reason that has to do with proprioception, and we're not going to get into that. Battle button. The battle button is the button on the string. Okay. And a lot of people might know this as a button pull, you might call it. Okay. So just so you know what we're talking about, let's make some updates for hypermobility for these 3 specific exercises. Okay. And then, just like how I explained to you what exactly these exercises were, main myo on the scroll down below helps to educate your patients in a significant way. Go to mainmyo.com. You can watch a demo and you can get 2 weeks free to kind of try it out and to see how you can educate patients 24/7 when they're up and you're not, when they're ready and you're not working, you're not on the clock yet. Okay. So, tongue pops. A suction hold is fine, but it shouldn't be at maximum opening for a person who is hypermobile. It would always be at 50%. 50% is the new max. So if you tell me that if you demonstrate to me during an evaluation that your maximum opening is 65. Okay, we're going to do a lot of our exercises probably with you around 30 millimeters as the opening. At most, I might have you at around 40, but we're never going to your max. Never. You will be more unstable the closer you get to that max, and you will be more likely to now have a different movement, a translational movement in your jaw that I am not seeking. So 50% is going to be the new max. And I want you to make sure that if there is any inclination that maybe we're going beyond that, that you're holding to support the jaw. That way you know it's not moving forward. And again, everything is with less reps. They will fatigue faster and they will need a lot more of the stability and support. And you'll probably see them in greater spaces or intervals of time. Okay. Tongue to spot. I do it with open, elevate, right? Or if I'm going to stabilize you, open, it's on open and elevate, right? Here's what we're not going to do. We're not going to have them open and elevate. We're going to have them elevate, then open. That's how we're going to manage the hinge and make sure that we're at our 50%. The stabilization you can get. So I might hold on to this for hypermobility. I'll hold on to a tongue elevation and grab a mouth prop. I want to say bear so badly because my people know I love my bear, and it's just so much easier to demonstrate. Like, bear is friend, not food. So you never want to clench down. Like, we're not biting on bear, we are resting our teeth. But I want to call it bear. But the mouth prop, I will introduce the mouth prop and have that come in as a support at their 50%, and then go on to elevation. But I will always start with elevate, and then open. It's going to work the muscles in a different capacity than open and elevate, but this is exactly what they need. A lot of times it just creates additional stability and muscle memory that we need to then move on. Battle button. Proprioception, I told you, people with hypermobility have difficulties with some proprioception. In my program, I use a 22 millimeter round button all the time for everyone, for kids, for adults, 22 millimeter round. However, with hypermobility, kids or adults, they might need a bigger button for better enhanced proprioception and the ability to really get around, seal, and then get a pop that is effective at their what you're trying to make now their new strength and awareness. Okay, so you're at a bigger button than you would use when you're doing a pull. Okay, awesome. All right, so it's nearly an hour of this, and you're like, cut to the chase, ma'am. What is it that we need to know? You need to know that if you're part of the bio community, you can request my quick guide and get that as a reference. Okay. However, what you really need to know as a myofunctional therapist is that small and controlled movements will manage your outcomes better. Do not go to maximum range. Do not try to maximize function. You're going to make something that is already quite loose, like our wavy guy in the beginning. You're going to make it more loose. You're going to make it more unstable. You're going to do the exact opposite of what you're seeking. Okay? We don't want those outcomes. So it's really important that you go less. Less is more. Controlled is more. Stability is key. Endurance is what you're trying to get to. You're maximizing that over the intensity. Posture matters. Breath work matters. Collaboration is key. Okay? This is us cutting to the chase. If you have questions, you know I am always, always, always here for you. Place them in the comments. We'll be back with another lecture next week. I am sure that something is going to pop over my face with the next video that you should be watching, because that's exactly how I do. Oh, yay! Somebody asked for my fun fact about giraffes. I think that is perfect. Okay, fun fact about giraffes. Ready? Giraffes have the longest tongues of all animals. Okay. Giraffes can stick their tongue all the way out. And I want you to think about their head shape when I tell you this. Stick their tongues all the way out and lick to clean their ears with their tongues. Whales have the biggest tongues, but giraffes have the longest. And a giraffe all the way out and around. Imagine how big that tongue is. And anybody who's ever fed a giraffe, it's exciting. It was very thrilling for me to be in Africa, in Kenya. Shout out to Morris and Safari and Smiles. But it was so scary too to be around a giraffe and its tongue coming out at me for food. And it looks so short. It looks like it's got nothing, but there's so much more of that tongue that you never see when you go feed giraffes. So even though you've done it and you've had that experience, you have not maximized a giraffe's tongue range of motion in any capacity. So, fun fact about giraffes. I love giraffes. I love tongues. They're my favorite thing in the whole wide world. Let me know in your comments your favorite thing. Love you all. I'll see you in the future. Bye, my old best friend.